Thanks, Bob. Thanks, Harry and Adam, for inviting me to attend. This is my first time at this meeting, and it's great to be back in San Diego, which is not that far from New Zealand. Just the other side of the pond. So I'm going to give a more clinical talk, and I was asked to talk in this. I'm really going to talk about predictors of antigen loss and what we've learned so far. These are my disclosures. I'll be talking about a number of investigational use, obviously, of a number of different hepatitis B cure programs, some of which I'm involved in, but many others. And my opinions are my opinions. Now, we all know why we're here. We're here looking for the goal of finite treatment for chronic hepatitis B in order to achieve sustained surface antigen and HBV DNA loss and no active disease and no need for ongoing treatment. And we all know the problems we face and what we need to do to try and fix up the problems. And this really has been the driver for developing new molecular entities. I've shown this slide many times. Thanks to virologists and immunologists, we've identified many new targets, both in the virus and the host, for new therapies, and this is really where we are in terms of ones currently in development. I've thrown in there in the lowering viral antigen burden the imminent arrival of gene editing, and we'll talk about that, I'm sure, later in the day, because I think this will have an impact on the scene, certainly within the next few months. Now, we're really going to talk about translation inhibitors, mainly how they reduce surface antigen load and how they may potentially improve the restoration of the host immune response and induce surface antigen clearance. And that's the topic for today, and I'll mainly deal with those drugs which are highlighted there. Now, translation inhibitors, first of all, I'll start by giving you an idea of how many phase 1b and phase 2 studies are currently underway and what combinations are used. You can see that almost all to date are using a combination of a backbone of an antiviral, usually a nuke, a translation inhibitor to low viral antigen burden, and followed or not by an immune modulator. And these are the certainly the ASOs with bepirovirsen now has been combined with a number of other drugs, both with immunomodulators, and we're about to see the new study combining it with another translation inhibitor in siRNA. I guess the biggest proliferation has been with siRNAs as a backbone with the nuke, and then adding in an immune modulator thereafter. And you can see the number which are currently, this has really just exploded, this field. A number of the studies are using more than one immunomodulator, so a nuke, an siRNA, plus 2 immunomodulators. And there are a very few number of studies where they're not using a translation inhibitor, and I really won't talk about those today. Well, I don't need to tell anyone in the audience about how translation inhibitors work. We have two groups, the siRNAs, which have to be delivered to the hepatocyte, can't be given naked, and then you've got the ASOs, which can be given naked or can be given Gane conjugated, but the move, as you see, has been towards naked delivery. A huge number have been developed, but a number have been stopped due to lack of efficacy or toxicity. And these are the ones currently in development in combination therapies. You've got the 3 siRNAs. These are not their new names. I'm sorry, I've used the old codes from Arbutus, Janssen, Roche and Vir. And then you've got 2 naked antisense oligos, the one we all know from GSK, bepirovirsen, and the new ASO from Auckland Bio, AHB 137, which we'll hear a lot more about during this meeting, during the meeting later this week. So siRNAs, what role can they play? We all know that siRNAs looked great in phase 1b, really quite profound drops in surface antigen and other proteins within the first 28 days, and really not a lot to distinguish the different types of siRNAs although they may have different triggers, X, S, or the Janssen, now GSK vaccine, which has both X and S triggers, but similar rates of surface antigen decline. But then the problem has been, and this predicted that you would make most people surface antigen negative, certainly within 12 months, hopefully within 6, but we know we didn't achieve that. And in the only trials we've given the siRNA for 48 weeks and beyond, we've seen plateauing of the decline after 16 to 24 weeks. Many theories about why that has happened, including saturation of the risk complex, but I think we're still unsure why we achieve this nadir, which is not negativity. So obviously this can be used to reduce surface antigen, but not by itself to achieve functional cure. Wonderful data from Arbutus. This is old data looking at, they were seeing ALT elevations with their treatments, and that has been seen in other siRNA programs, mild ALT elevations, and they provided the first data to suggest that you are restoring some HBV-specific immune control with surface antigen reduction with siRNAs. And I think that this is really important data. They showed certainly T-cell activation and also reduced T-cell exhaustion. This data is interesting. The more recent data from the IMPROVE study, where they combined it with pegylated interferon, you recall, presented at EASL, suggested an increase in PD-1, PD-L1 markers, which is a bit difficult, but that really, if anything, that suggested that maybe there is a role for checkpoint inhibition when using siRNA therapy. This data is very well known. It's published now by the New England Journal, by MF, who's in the audience. Really, this data, different regimens, different doses, 12 or 24 weeks. If you stick to the arms on the left, where you get the highest dose, 300 milligrams, with loading dose and then weekly, you can see good end of treatment responses of 17 and 28%, but there was a post-treatment relapse rate. So you're getting around a 10% sustained surface antigen loss or functional cure, and that appears to be sustained, and that is in an overall population. This appeared to be associated with ALT elevations, so it was a very good association between ALT elevation and surface antigen clearance, and subsequently almost all patients who had a significant surface antigen decline had an ALT elevation or ALT flare. And beautiful data has shown, as you know, in vitro, certainly in the models, evidence of TLR8 activation, and some data in patients in the Be Clear study suggesting that surface antigen decline could be closely correlated with ALT elevations and cytokine levels associated with TLR8 activation. So I think that was very good idea as to one of the modes of action of this naked antisense oligo. Now, really, we've looked at the translation inhibitors, which are going to be the backbone of most of the combination regimens going forward. We'd like to know, what are the predictors of surface antigen loss? Right. Well, we have, of course, the holy grail of pegylated interferon. I've just shown you this meta-analysis because the numbers are huge, but you're well aware from the individual studies from Pegasus and Pegintron that the best predictor for surface antigen loss or functional cure following pegylated interferon monotherapy is a low baseline surface antigen level. The lower, the better. All these other factors, the demographic and viral factors, have some effect, and they are significant, but by far and away, a low surface antigen level less than 1,000 is the best predictor of loss and seroconversion after a course of pegylated interferon. The Everest study, which is often quoted now, this huge study out of China, where they converted almost 3,000 e-antigen negative patients suppressed on NUCs to either add on or switch to pegylated interferon for 48 weeks. Similar results, I think, very encouraging results. And you can see that the rate of functional cure was determined by the baseline surface antigen level, that's before they went on the nuke, and the ALT level 12 weeks after starting the pegylated interferon. So these two markers for add-on confirm that baseline, again, surface antigen level is the best predictor of functional cure with pegylated interferon, either as first-line therapy or as second-line therapy. But ALT elevation on treatment is also an important predictor. And they also showed, as I think Roche showed in their registration in the Neptune studies, that the dynamics of surface antigen on interferon, in particular the absolute levels at 12 and 24 weeks after starting pegylated interferon, is a very good predictor of functional cure. But again, the most significant was the baseline surface antigen level. Coming back to antisense oligos and bepirovirsen, I've just shown you the nuke suppressed, but the nuke naive data is very similar. That in the two top arms, that's remember they're the 300 milligram arms, it was the surface antigen level of less than 3,000 was the most important predictor of off-treatment sustained surface antigen clearance or functional cure. And some nice modelling was done by Yusuf and presented at this at the AASLD meeting a couple of years ago, which showed that the lower the surface antigen level going from left to right on the x-axis, the higher the rate of functional cure. This was modelling. They subsequently did error under the curve statistics to show that certainly 3.5 logs or 3,000 was the ideal cutoff in terms of positive and negative predictive value for achieving functional cure with bepirovirsen. And that 3.5 or 3,000 did become, therefore, the inclusion criteria for their phase 2 program. So antisense oligos, longer duration, up to 24 weeks, higher dose, 300. On-treatment ALT elevation, I pointed out that that's certainly strongly associated with functional cure, but most importantly, a surface antigen level of less than 3,000 again. What about the other antisense oligo? The data on this is still emerging. I presented some of the phase 1 data at AASLD, but there will be phase 2 data presented, I think, at the meeting later this week. This is, again, a naked ASO. It appears to be highly active in vitro, high potency, and in the initial study certainly didn't appear to activate TLR8 pathway. And the ALT elevation seen in the clinic appear to be associated with surface antigen reduction. And this is the data from AASLD. All you can see is a number of people are having profound surface antigen losses after only 28 days. 5 out of the 40 or 13% achieved surface antigen loss. On the right graph on the base, you can see it doesn't appear to matter with a higher dose, the 300, what the baseline surface antigen level. And this raises the possibility is, can you increase the potency of your antiviral to overcome the predictive value of the baseline surface antigen? So yeah, the rates were the same. In patients above or below 1,000, they used that as a cutoff. There weren't patients in the study above 3,000, so that may be a limitation of this. But certainly, the 1,000 cutoff had no relevance. And as I said, ALT elevations for this compound weren't seen in all patients. What about the siRNA elebsiran? This is a siRNA. Are you aware of this data? This is part of the data with or without pegylated interferon, and the regimens are shown there. So 2 different doses of the siRNA and 3 different doses of the pegylated interferon, and you can see the end of treatment results and the sustained responses. Just to point out that there is a relapse in both groups, but in the interferon-free combination, that's the siRNA and the nuke, is not sustained. So you're only seeing sustained surface antigen loss with the addition of pegylated interferon. And the other important finding from this study is that surface antibody, the development of surface antibody at the end of treatment did appear to be associated with sustained surface antigen loss or functional cure. And the data, scatter plot shown on your right, the data on your left. In patients who had surface antibody levels of more than 500 at the end of treatment, all of those patients achieved functional cure. Whilst those patients who had surface antibody levels below 100 at the end of treatment, all of those relapsed. So there appeared to be a continuum in terms of protection. Yep. So longer duration of pegylated interferon for this combination, lower baseline surface antigen and higher end of treatment surface antibody. This is the Roche combination, and here they use, they substitute in for pegylated interferon in one of the arms, risotolumab, which is a TLR7 agonist. And you're aware of this Piranga data, it's been presented now twice. Multiple arms are shown here with a nuke control. So you have the nuke and the siRNA, one arm with the TLR7, one arm with the pegylated interferon. These are the results. Certainly the combination with immunomodulator appeared to be important in achieving surface antigen loss compared to an siRNA and a nuke alone. As we saw in the previous study, you need an immunomodulator if you're using an siRNA and a nuke. Again, lower baseline surface antigen, as in the previous studies, and they used a cutoff of 1,000. If you had a baseline surface antigen of more than 1,000, no patients achieved functional cure, whilst almost a quarter of those with a baseline surface antigen of less than 1,000 went on to achieve functional cure. And one of the more recent combinations from Ver is combining an siRNA with a surface, anti-surface monoclonal antibody. This is the March study. This is the first part that was presented a year ago. So their siRNA plus their anti-HBs tobevibart, plus or minus pegylated interferon. Now you can see in the interferon-free arm, it was very much like the nuke and the siRNA I've shown you in the last two studies. You weren't achieving functional cure. Although you had some end of treatment surface antigen loss, off treatment, all patients relapsed. However, when you added pegylated interferon, that overcame this. And pegylated interferon led to sustained surface antigen loss after you completed treatment. So, as the previous two studies shown, an siRNA plus a nuke plus an immunomodulator does achieve functional cure in a small proportion of patients. But again, the most important predictor is the baseline surface antigen. Ver looked at a cutoff of 3,000, and you can see on the left, there's teal is end of treatment, crimson is follow-up or functional. That's only at 12 weeks, I should say, but it's hopefully going to be sustained. You can see that you didn't achieve, you achieved on treatment surface antigen loss in 23% of patients in the interferon-free arm. If you go to the right, you can see in patients with surface antigen levels above 3,000, no patients achieved either on-treatment surface antigen loss or post-treatment sustained loss. So certainly 3,000 again appeared to be their predictor of whom would respond to treatment. Yep. And they also suggested longer duration may be important, and the longer duration, up to 48 weeks, will be presented at this week's American meeting. So this was only 24 weeks of these combinations. 48-week data, end of treatment data, will be presented at the meeting later this week to see whether longer duration can actually get you to functional cure without interferon, longer duration of this combination. The improved data, again, another siRNA, again, plus or minus interferon. In fact, this is only the interferon data I'm showing here. The top two graphs are 24 weeks interferon. The bottom two graphs are 12 weeks interferon. And so you can see that it's the duration of the interferon appears to be important, not just the addition of interferon. So longer duration of interferon, again, the baseline surface antigen was an important predictor. All patients who achieved functional cure had a baseline surface antigen of less than 1,000. And again, they showed that the end of treatment surface antibody titer was also important. They looked at a lower threshold, but as in the previous studies, surface antibody, lower baseline surface antigen. What about getting away into the newer immunomodulators? And this is the study from Exelixis using ASC22. I'm sure we'll hear more about this today. This is an interesting study. This is their phase 1 study where they treated patients for 12 weeks. And here the results are just plotted according to their baseline surface antigen. And you can see quite clearly that the only group who appears to respond well are the group with a surface antigen level of less than 100. And of those 7 patients, 3 of them achieved functional cure. Then they remain surface antigen negative off treatment after 12 weeks of an anti-PD-1. The bottom figures show you those individual patients. All of them had a hepatitis flare, ALT flare. So certainly for an anti-PD-1, if you are going to go down this road of using this, you'd expect this to be associated with hepatitis flare as part of surface antigen decline and loss. Yep.
Sorry, Ed, your time
Yeah.
is over.
Okay. So a therapeutic vaccine, this is the other one. What are the predicted surface antigen loss? Well, the therapeutic vaccine has been used, and again, in this early data you'll hear more about later, the surface antigen level of less than 200 was associated with decline. Loss hasn't been seen in this study of therapeutic vaccine followed by anti-PD-1, but certainly decline is. Okay, so these are the predictors of sustained loss. Baseline surface antigen, different studies have used different cutoffs. Addition of peg latent interferon, on-treatment ALT elevations, end of treatment surface antibody levels. And longer treatment duration may be important if toxicity allows. What I haven't given you is any data on other demographic or viral predictors of surface antigen loss with any of these regimens. And to date, we really don't have a good feel as to whether any of these are independently associated. So how do we enhance surface antigen loss? We can restrict treatment just to those patients with a low surface antigen, and this again is the data from USF. That is an issue. The lower the threshold, the less patients in your clinic you'll be able to put into the trials. This is their simulated data, which included, I believe, European patients, where you suggested if you use 3,000 as a cutoff, it'll be about 50%. If you use 1,000, it'll be 26%. The real world, and I'm part of the real world, Asia Pacific, we have very similar populations, but I thank MF for this data from a huge number of patients, and they presented this at AASLD. It's quite different. I think the numbers with lower surface antigen levels in the real world are actually much lower than we think. This is overall, you can see around 80%, around 70% of treatment naive will be below 3,000, and overall around 90% of nuke suppressed will be below 3,000. It's even more marked for the E antigen negative patients, as you can see here, where for the E antigen negative patients, almost all on nukes have baseline surface antigen levels below 3,000, and in fact, the majority have a baseline level below 500. So I think it is giving us a bigger population if we are going to restrict who we put in these trials. The real world data now are showing that patients with on nukes, especially surface antigen level patients, most of them will have lower surface antigen levels. Just skip over that. And so that compares to the data I showed you in the model. You can see it's very, very different in the real world. If you use different cutoffs, there can be far, far more people who will fit in underneath the threshold for the new studies based on what we're actually seeing in the clinic. How do you enhance? Finally, we've got the wonderful data from Ursa Protzer combining, doing a lead-in surface antigen. Will that work? If you reduce the surface antigen artificially by giving a translation inhibitor, does that the same of having a low baseline surface antigen? Well, certainly in mice, it appears to be incredibly effective strategy. And in this small study, all mice were cured by using lead-in prior to the therapeutic vaccine. What about patients? Again, this is very preliminary data, again from Barinthus and Arbutus, where they're looking at this using imdusiran, lead-in, and you can see that all patients, or almost all patients, suppressed below 100 by the end of the lead-in, and it's the addition of the therapeutic vaccine appears to maintain the response after you stop treatment, whilst in the patients who just got the imdusiran, they tend to get a slow rebound. This data is very, very preliminary, and we haven't seen surface antigen loss yet. And finally, what about targeting cccDNA, the Holy Grail? And I think we're going to hear more about that. That would certainly lower surface antigen rates, and maybe that would be a great strategy, if not successful on its own, to add to other strategies that this will profoundly reduce surface antigen. It may not eliminate it, it may be transient, we do not know, but that's something, given the numbers of programs currently under development, something we should look at. So, to finish, really the only reliable predictor across the regimens with loss with immunotherapy is a low baseline surface antigen level, and the lower the better. There's some evidence from Arbutus and others that lead-in siRNA may restore host immune responses, but we're not seeing many flares with siRNAs. And to me, it's still not clear whether a reduction of the surface antigen by a translation inhibitor is the same as having a low baseline surface antigen, and whether it will dramatically increase the efficacy of immunotherapies. I think we may need more rapid and profound surface antigen declines if we are going to see this immune restoration. And I think we have the tools at our fingertips to use. There are also going to be some new, very potent tools coming up, as I mentioned, the gene editing approaches. Now, I'd like to finish. We are in San Diego. I'm not sure whether many San Diegans are in the audience, but if you recognize this is the old mug, the America's Cup. Now, that has great importance for San Diego. It was in San Diego that a young America lost the cup to Team New Zealand. I just want to point out how America's Cup technology may reflect what we're developing in the hepatitis B treatment. These boats, you had about 30 people on the boat. They went 8 to 10 knots. Technology changes things. We had plastic boats which cracked up. We now have boats like this. This is the boats, our boat which recently re-won the America's Cup. I'll just put a bit into that. In Barcelona last month, we won it from Britannia. These boats are carbon fibre. In 12 knots of wind, they go 50 knots. These boats are truly incredible to what technology can achieve. So I think with that, that inspires me that we will achieve hepatitis B cure. I'd like to finish by thanking many of you in the room, actually, who helped me with the slides and with this presentation. Thank you.